All right. Next type of shock we're going to get into is hypovolemic shock. All right. So this is video number 3, hypovolemic shock by Kyle Ortega. All right. So what is hypovolemic shock? It occurs when there is severe loss of blood or fluids leading to insufficient volume in the circulatory system. Results from trauma, dehydration, excessive bleeding, things like that. There's two types, hemorrhagic, and non-hemorrhagic. So one's by significant blood loss and one is by loss of fluid. So blood loss, like GI bleed, trauma, postpartum complications. Um, Other types include, diarrhea, burns, um, severe vomiting, dehydration, things like that. So some physical examination findings. Uh, you're going to see tachycardia is really big to compensate for that decreased blood volume, hypotension, which, insufficient blood volume, tachypnea, because the body's trying to increase its oxygen intake. And then cool, clammy skin. You got weak, absent peripheral pulses, altered mental status, some confusion maybe, unconsciousness, and then delayed capillary refills. All right, so signs and symptoms of hypovolemic shock. So you're going to get some paleness, severe bleeding, dehydration, burns, dizziness, urine out, decreased urine output, hypotension, and then increased the heart rate's going to be up, tachycardia. So that's pretty much telltale signs of it. Um, and then now we're going to talk about so we got mild, moderate, and severe shock. So shock less than 20% of blood volume loss, vasoconstriction begins, redistribution of blood flow is shunted to all the critical organs. And moderate shock, which is 20 to 40% of blood volume loss, decreased perfusion of organs such as kidneys, spleen, your pancreas. And then in severe shock, which is over 40% of blood volume lost, it's a very big perfusion of decreased perfusion of the brain and the heart. So pretty much with hypovolemic shock, you just got low blood volume. Um, Imaging studies, you got ultrasound, which is used to detect that internal bleeding or fluid accumulation in the abdomen or chest. CT scan identifies sources of bleeding trauma with detailed images of internal structures. And then chest x-ray, which assesses for fractures or injuries that may be causing bleeding fluid. So, and also checks for pulmonary edema. All right, next we're going to talk about hemodynamic monitoring when it comes to hypovolemic shock. So again, we're going to use that Swan scans, pulmonary artery catheter to measure our cardiac output, pulmonary capillary wedge pressure, and then our pulmonary artery pressure. We're going to use a central catheter to measure central venous pressure as well. All right, so we're going to have decreased volume, which leads to decreased stroke volume, which obviously is going to decrease cardiac output, and it's going to increase that heart rate to compensate. All right, so we got decreased CVP, got decreased pulmonary capillary wedge pressure, but then we got, and also decreased SATs, and then we're going to have increased systemic vascular resistance as the body is going to try to compensate. So the pharmacology and treatment for hypovolemic shock, the most important is that fluid resuscitation. Um, we just want to get our volume, uh, get our blood pressure back up, but we're losing a lot of volume, so we want to try to replenish all that. Vasopressors, dopamine, norepinephrine to improve our blood pressure, cardiac output to try to get back to homeostasis. Then Zecnil is an anti-secretory agent. It's got similar effects as vasopressin, but It doesn't cause coronary vasoconstriction. Also, we're going to be using blood products, addressing the underlying causes of the hypovolemic shock to better treat as well, which is probably very critical to the treatment. And then we're just going to continue monitoring our patient. Next, we're going to talk about our blood gas abnormalities and mechanical ventilation. All right, so we'll start with our ABGs. So metabolic in hypovolemic patients, you see metabolic acidosis because of inadequate perfusion, tissue oxygenation, respiratory alkalosis because the body's initial response is going to be hyperventilating, and then as the shock progresses, it's going to shift more towards increase in the PaCO2, so there's going to be a respiratory acidosis. And then, so for mechanical ventilation, for ventilatory failure, reduced peak levels, high respiratory rate, but low tidal volumes. But in fact, you want to use 0 PEEP until the circulating volume is restored. That's what I found in my research on this shock in mechanical ventilation. But our positive pressure ventilation concerns do include it may diminish venous return, which diminishes cardiac outcome and worsens the shock state. So it just can be detrimental for a patient suffering hypovolemic shock. There's a high risk of cardiovascular collapse, even in moderate level PEEP. So real big emphasis on not much PEEP with this type of shock. All right, so to kind of summarize everything up with hypovolemic shock, it's basically a direct loss of effective circulating blood volume, internal and or external, which primarily leads to decreased cardiac preload, stroke volume, and consequently impaired end organ perfusion. The hemodynamics, the cardiac output, central venous pressure, pulmonary capillary wedge pressure, they all decrease while heart rate, systemic vascular resistance increase. And then the main treatment for hypovolemic shock, we want to stop the bleeding, stop the fluid loss. That's most important. So finding that underlying cause, going back to, like different types of GI bleeds, trauma, postpartums, and then the non-hemorrhagic burns, vomiting, diarrhea. So we want to find the cause, stop it, stop that loss, replace the volume, vasopressors and blood products, and hopefully we can have better outcomes for our patient. So that wraps up hypovolemic shock. And like I said in the last video, all my sources will be at the whatever video I do last. It'll be at the end of that one, just to because it's like 3 or 4 slides, so I don't want to bore you with that over and over. All right, thank you very much for watching.